Good evening. Let's take some time today to reacquaint ourselves with the nuances of hydroxychloroquine therapy and its effect on the ocular system. Hydroxychloroquine is an anti-inflammatory drug, an effective alternative to chloroquine with a presumed smaller adverse effect profile. However, as the drug found its use for a variety of chronic systemic disorders, it was also found to be associated with a plethora of adverse effects, most sinister being drug-induced retinopathy. It is widely used in rheumatological practice, with systemic lupus erythematosus, rheumatoid arthritis, and Sjogren's syndrome being the commonest indications. The drug is also used in various dermatological, oncological, and pediatric conditions. The drug was also experimented with during the research for effective treatment for COVID-19 pandemic. The effect was found to be inconsistent, and a requirement of a dose which was much higher than routine raised concerns regarding potential early onset adverse effects in the future. Contraindications of hydroxychloroquine are few but important, including known hypersensitivity, pregnancy, pre-existing retinopathy, and concurrent use of other drugs like tamoxifen, which cause retinopathy. The dose of hydroxychloroquine needs to be carefully calculated. Earlier, ideal body weight was used for dose calculation, and a dose of 6.5 milligram per kg per day has been suggested. However, it may not always be possible to calculate the ideal body weight of all patients, especially in a busy OPD setup. Also, it is fraught with the risk of overdosing in very lean patients. So now an actual body weight dosage is used with 5 milligram per kg per day recommendation. It is also associated with risk of overdosing in obese or shorter patients. So for all practical purposes, a dose of 200 to 400 milligram per day is considered safe and effective. The adverse effect profile can be divided into ocular and systemic. Ocular side effects can be non-retinal, which are generally dose-related and transient, or retinal, which is irreversible and progressive. The drug can affect almost all organ systems of the body and rarely can cause hypersensitivity reaction as well. Non-retinal adverse effects are rarely seen and include accommodation defect, transient corneal edema, cornea verticillata, and reduced corneal sensations. Retinal adverse effects range from deficient color vision, visual field defects, pigmentary changes in macula and peripheral retina, arterial attenuation, and optic atrophy, comprising the spectrum of progressive hydroxychloroquine toxicity. Retinopathy is by far the most researched adverse effect, initially considered rare, with widespread use of the drug and evolution of specialized investigative modalities in ophthalmology. The prevalence has been found to be higher, albeit variable, likely due to underreporting. A milestone prevalence study was conducted in 2014 at Johns Hopkins Institute by Mellis and Marmor. It showed wide prevalence depending on dose and duration of drug use. This study formed the basis of recommendations of the American Academy of Ophthalmology in 2016. Other studies, as mentioned, have shown variable prevalence worldwide. A study conducted by us in 2021 among 100 patients over a period of 1.5 years showed a prevalence of 15%. The risk factors for retinotoxicity are dose and duration of drug, although low dose over a prolonged period of time has also been associated. Pre-existing ocular pathology such as glaucoma, rod cone dystrophy can confound the results of investigations and also influence the progression of retinotoxicity. Some drugs like tamoxifen are independently associated and aggravate hydroxychloroquine-induced retinotoxicity. Concurrent hepatorenal disease, use of cytochrome P450 inhibiting drugs and genetic factors have been associated. Elderly patients and women have been found to be more predisposed. HCQ is a lysomotropic drug, which is an inhibitor of autophagy. It binds to non-pigmented tissues and melanin in pigmented tissues. In the eye, melanin is found in uvea and RPE, where it has important antioxidative functions and provides protection against light toxicity. HCQ, when bound to melanin in the RPE, specifically inhibits the cellular uptake of all trans-retinal, which leads to phototoxicity. HCQ retinopathy is mostly discovered during screening. The commonly encountered signs are visual field defects, macular and peripheral retinal pigmentation with arterial attenuation and optic atrophy, in advanced cases giving a rod cone dystrophy-like picture. Color vision defects are inconsistently seen. A very rare sign is cystoid macular edema. Some atypical presentations have also been reported, including accelerated and asymmetrical retinopathy. Coming to effective screening methods for HCQ retinopathy, spectral domain OCT macula has been the cornerstone for diagnosis. It shows involvement of outer retinal layers and relative sparing of inner retinal layers, which may cave inwards depicting the famous but not pathognomonic flying saucer sign. Advanced disease shows severe thinning of all zones. These are the OCTs of some of the patients from our study. They show a relative sparing of foveal center till advanced disease. The characteristic flying saucer sign-like picture is also noted in the middle photo. Perimetry enables early detection of asymptomatic scotomata. However, it is important to note that no specific pattern of field loss can be expected, and fields may not always be consistent with other findings. These are some types of field defects that can be seen during screening. Here we can see a symmetric retinal thinning on OCT in both eyes with similar clinical picture, but with grossly different visual field findings. Fundus autofluorescence has been found to reveal parafoveal hyperautofluorescence with foveal sparing due to accumulation of lipofuscin within RPE liposomes. A bullseye maculopathy may be detected on autofluorescence before manifesting clinically. As seen in this picture, the pigmentary changes at the macula have not yet taken the form of bullseye maculopathy. However, the same can be clearly demonstrated on fundus autofluorescence. When correlated with OCT macula, bilateral bullseye maculopathy in this patient is associated with severe foveal thinning in all zones. Multifocal ERG has been promoted as an objective method for assessment of photoreceptor function. A 5-ring stimulus reduces acquisition time with comparable results compared to 61 hexagon stimulus. This test is 93% sensitive and 97% specific for XCQ retinopathy. Microperimetry is a combination of visual fields superimposed over fundus imaging over central 20-degree area of fixation. The test is 73% sensitive and 93% specific and is not recommended for primary screening due to low sensitivity. Novel investigations include OCT angiography, modalities of novel OCT analysis, use of adaptive optics and multicolor imaging. However, they have not yet made their way into the recommended screening guidelines. Investigative modalities which were previously considered important but are now outdated include fundus photograph, color vision, Amsler grid, and fundus fluorescent angiography. The best way of detection of retinopathy today is the use of multiple investigations, as no single investigation has been found to be diagnostic for retinopathy. The 2016 guidelines by the American Academy of Ophthalmology are currently followed worldwide. It recommends a baseline fundus examination before starting HCQ, followed by annual screening starting at 5 years of treatment. The Academy suggests OCT and perimetry as primary investigations with ERG and autofluorescence as supportive for diagnosis if available and required. The Royal College of Ophthalmology differs slightly from American Academy in its recommendations. It suggests the onset of screening based on risk factor profile and recommends OCT and autofluorescence as primary tests with perimetry and ERG to be used when both OCT and autofluorescence are not simultaneously positive. There is no treatment for established retinopathy. Sporadic reports suggest improvement in vision and fields after drug cessation. However, this is not universal. Rare cases with cystoid macular edema have been managed with acetazolamide and dexamethasone. However, the primary management remains cessation of hydroxychloroquine and substitution with alternative therapy. Eliminating risk factors, correct dose calculation, screening with discipline, and developing facilities for the same are vital to primary prevention of HCQ retinopathy. This is in fact the need of the hour to streamline screening systems in our country, where hydroxychloroquine is very commonly used in clinical practice. To conclude, irreversible retinopathy makes hydroxychloroquine an important drug subject to monitoring. Careful dosage, risk factor assessment, and disciplined approach towards screening strategies are the only ways to prevent retinopathy in patients with chronic systemic disease. These are some of my references. Thank you.
Thank you, Doctor.
Thank you so much. So one point that you made was, yeah.
Can I ask one question? So for the screening, I might push to the whole panel also. For the screening purpose, AO recommends 10-2, but for Asian population, they do recommend 24-2 or 30-2. What do you people practice?
I mean, at our center, at baseline, we are doing a visual field 10-2 and an STOCT. These are the two ones. 10-2.
10-2.